Okay, so now we're going to talk about the complications that we have because of all the types of diabetes mellitus. Okay, so type 1 and type 2 included. Remember, gestation will go away after pregnancy, so these mostly involve our type 1 and type 2. So the first very common type of diabetes complication that we get is diabetic neuropathy. So that's where our peripheral nerves start to dysfunction. They get damaged because of the neurological effect of that increased glucose on our circulation and vasculature. And we end up with peripheral nerves slowing conduction signals, and our conduction may actually end up causing pain and numbness, tingling, things like that along the paraplegias. Microvascular, remember micro has to do with small, so we're talking about very small vessels, so microvascular disease. Hyperglycemia actually causes thickening of those capillaries in their membranes. So remember, the capillaries are the tiny blood vessels where you actually transfer your oxygenated blood and your venous blood for your circulation. So what we're saying is that those increased sugar levels are going to cause thickening of those capillary walls, and that's going to make it more difficult for perfusion to occur. So overall, you get a decrease in tissue perfusion. Our eyes and the blood vessels in the eye are some of the tiniest that we have in our body, so especially the retina and the kidney, because our kidneys are very vascular. Remember, they do a lot of circulatory work for us, a lot of filtering of our blood. So in the United States, actually diabetes is our most common cause of end-stage renal disease. Retinopathy is where we have damage that's going to happen to those retina and those retinal blood vessels as a result of that decreased blood flow ischemia that's going to happen with that thickening of the capillary membranes. So because they get thick, our blood flow gets diminished, and they're so tiny, our red blood cells can actually get stuck, and you would get aggregation that can mean that they'll clog up or clump on each other in these tiny vessels. As a result, they're going to cause loss of vision. So if we actually look over here to the picture example, this one would be a normal eye, and when we're looking back in at the retina and the optic disc of somebody's eye on an eye exam, here we can see all these tiny white dots. Those are actually the platelet aggregation that happens that is causing damage to our retinal blood vessels, and it's going to result in vision loss. Now, complications of diabetes can also continue. We're going to talk about macro, so think big. Macro means big, and vascular, we're talking about vessels. So big vessels are macrovascular disease. Remember, think back to when we talked about cardiac and coronary artery disease. So with diabetes, you can have a premature onset of that atherosclerosis. That means you're going to have increased triglycerides. Our healthy or HDL cholesterol is going to go down. Our bad or LDL cholesterol is going to go up, and that increases our risk for coronary artery disease. Stroke and heart attack, or MIs, are also the most common cause of death in people who have type 2 diabetes. So we clog those arteries, we change their vascular flow, they're at increased risk for a stroke or heart attack. Mortality is greatest if it happens at or before middle age, especially if we're women. All right, and for heart attack, the cause of death is 20% for all of our patients who have diabetes mellitus. For stroke, it's actually 2 times or twice as common in patients who have diabetes. Other macrovascular diseases include our peripheral vascular disease. So remember when we talked about this with circulation in the heart as well. So remember that has to do with our larger circulatory systems in our peripheral sites. So our legs, our feet, our arms, our hands. So peripheral vascular disease, you're going to have atherosclerosis again. It's going to cause that narrowing of the lumen of our large blood vessels. It's going to happen at a younger age if somebody has diabetes, and it's also going to occur and progress faster in somebody who has diabetes. In the U.S., most of these are going to cause gangrene changes. So this is why we're very careful about instructing clients to check their feet, make sure that they are looking for sores, making sure they have proper fitting shoes, good circulation, washing them. because over time, if they get a sore and it gets infected and gangrene and their healing time is delayed because of the peripheral vascular disease, we can actually lead to sores and wounds that will not heal. And if that happens, then we have to amputate them. So that's actually 50% of all our amputations that are due to non-traumatic causes in the U.S. are because of clients who have diabetes and they end up with peripheral vascular disease and wounds. So they're also at increased risk for infection. Okay, so a couple of things happen whenever we look at clients who have diabetes mellitus. One, they have poor vision and poor sensation because we've damaged those blood vessels to the eye and we're changing and damaging those neuropathy or neuropathic changes that have them feel sensation. So they may step on a rock, they may step on a pin or something and get a sore on their foot and not even feel it. They're more clumsy or likely to have accidents because they can't see as well. Now we're also decreasing that vascular blood flow to them. So that means that we have a decreased oxygen supply to our tissues. Our tissues need oxygen in order to be healthy, to get circulation, metabolism, and all that kind of stuff. So if we decrease their oxygen content, we're going to make it more likely for infections to occur and harder for them to heal. Pathogens are also likely to multiply more rapidly or grow faster because of the elevated glucose in the blood. So bacteria, funguses, things like that, they like sugar. It helps them to grow. It gives them energy to metabolize and reproduce as well. So because we have extra sugar floating around diabetic patients in their blood, when they get infections, it will spread faster and will be harder to treat because you're essentially feeding those bacteria and those pathogens more nutrients that they don't need, and it helps them to grow faster. The vascularity also is going to decrease the response time and the amount of white blood cells that we have and when they're able to get to an infected site. And the function of the white blood cell itself is not used to working in high glucose concentrated environments, so they can't work as well. These images here are some of peripheral vascular disease and wounds on somebody's foot. This is a cellulitis that somebody got probably from a bug bite. You can kind of see it right there and how it had spread and didn't heal. And then this is actually a yeast infection in the skin folds of somebody with diabetes and mellitus. They will tend to get them in more irregular places like the armpits or under the breast or in the fat folds of the abdomen. Because again, the yeast can grow really well due to that high glucose concentration. So this information is found on this website here, diabetes.org, along with a lot of other things if you're interested in finding some more resources or know somebody who has diabetes. But diabetes and the management of it can be pretty complicated. People who have to have glucose monitoring, they need to do that by pricking their finger, usually. So what they have to do is do a finger stick a certain number of times a day. Now, most people, it's at least in the morning and at night, if not before meals too. So they have to poke themselves. They have to get a reading. They put their blood sample into a special meter. It tells them what their glucose concentration is. You can imagine that over time, or even if you have a younger individual, like a teenager who's battling diabetes or things like that, this can be very cumbersome and people will not want to do it at times. So compliance can be difficult. Also because we often have to gear the dosing of their medications around these readings as well. Their diet, we want them to eat a regular, well-balanced diet that has good proportion sizes. They should limit their carbohydrate intake because carbs break down fastest in the simple sugars. And they should eat at regular intervals throughout the day. So no skipping meals. They're going to experience more highs and lows in their glucose level. They should always carry a quick source of glucose with them in case they do experience hypoglycemia. This can be things like a piece of candy, some juice, things that have simple sugars in them that can be metabolized quickly. If they're a brittle diabetic, and this happens frequently, they may carry like an oral glucose gel with them as a quick source of energy, but that could help pull them out of a hypoglycemic state if they have a large dip or swing down in their glucose level. If we can get them to increase their exercise, it's going to reduce that need for insulin and help with the uptake and the use of it within our body system. So we would encourage to have exercise and regular exercise, even if they need to start slow and work their way up. You know, maybe it's just walking for 10 minutes a day and then they build up from there. If we can't manage them with diet and exercise, then we would recommend that they start on oral anti-diabetic medications. So these are things like your glucophage and your metformin, where they're geared at helping with our insulin-resistant type problems that people have with diabetes. If they have insulin insufficiency, or if they're type 1 diabetic, or they haven't responded to oral medications, they will need to be on insulin therapy. So that's where they have to actually take some type of insulin. Now we have short-acting and long-acting and various different modalities anymore. But they would have to take insulin therapy to regulate their sugar. So depending on that reading that they get during their glucose monitoring, they'd have to take a certain number of units of insulin. For people who have brittle diabetes, meaning that it's very hard to manage with intermittent insulin therapy or oral medication, or type 1, they may end up with an insulin pump. So an insulin pump goes directly into the skin off of a little device that's filled with insulin, and it will give them an infusion of insulin continuously or at regular intervals directly into their circulation. Now, they can also have the ability to bolus themselves. So say they eat something that's high in carbs, or they have a piece of cake, they could give themselves a little extra insulin whenever they need it to help them regulate their disease too. And for type 1 folks, if it's really a dire need and they can't be managed on the insulin pump and the medications and things, then they would be candidates to have a pancreas transplant so that they could actually have a pancreas that would produce the insulin that they need to survive. Okay, so that is the end of our diabetes material in our lecture. So remember, what I'd like you to do is to go find that case study, the corrected case study, and compare it, self-correct yours, make sure that you have everything squared away to study for the exam, and then you can work on your blog, your last bar list after holiday break. Thanks, guys, and always feel free to email me or call if you have any questions or concerns.